Hello, and welcome to this short webinar on looking at hip strength and mobility in patellofemoral pain. My name is Binoy Matthew, one of the tutors on the running course hosted by Physio UK. The main emphasis of the talk will be on running specific research. I work as an extended scope practitioner, mainly looking at lower limb injuries in the NHS and also in private practice. A majority of my patients tend to be overuse runners or lower limb injuries. Now, looking at patellofemoral pain, so we know that runners tend to get a lot of injuries, and the yearly rate is around 70 to 80%. And the key injury tends to be around the knees. So 40% of all running injuries is directly linked with the knee. And the number one injury tends to be patellofemoral pain. Patellofemoral pain has traditionally been viewed as self-limiting. So generally we thought they get better with rehab, have good outcomes, but more and more studies have shown that a large majority of patients tend to have pain at long-term follow-up. So we just included one recent study which has not been published but is available online on BJSM, which looked at data from two RCTs, and the surprising finding was more than 50% of participants tend to have an unfavorable recovery 5 to 8 years after recruitment. So although they do get better, but it seems to be an ongoing issue. So it's definitely a clinical challenge, especially in the active population, and it's multifactorial. I'm going to mainly focus on the proximal factors on the management of patellofemoral pain, which tends to be hip strength as well as hip mobility. For the last 10 years, we're getting more and more evidence for the role of hip strength. I've just picked up one RCT and one systematic review looking at the influence of hip strength in patellofemoral pain. This is a really well-designed RCT which was published this year. Very good numbers. We're looking around nearly 200, and most studies tend to have mainly females, whereas this had sort of equal number of both men and women, and the average age was around 29. And what they found out was divided into two groups. One just had your traditional knee protocol, mainly looking at quad strengthening. The other group had both hip and core, mainly focusing on proximal stability. Both the groups had improvement, and for me the most interesting finding was the hip protocol had early resolution of pain and better outcomes, and that is really useful information. So somebody with an acute knee, painful knee, maybe you could focus on the hips initially, and once the pain gets settled, you could start loading the knees. Now, the next piece of research which I've used here is an excellent systematic review which was done by Simon Lack and colleagues, published in the BJSM again this year. They looked at nearly 14 studies and 7 were of really high quality. And the conclusion matched the previous RCT, where it shows that it's pretty much effective than quad strengthening in decreasing pain in the short term as well as in the medium term. So we got very good level 1 evidence both from multi-center RCTs and well-designed systematic reviews about the importance of proximal stabilization in the management of patellofemoral pain. The talk I'll be mainly focusing on hip mobility. So there's more and more research looking at the importance of hip mobility. The first piece of research which I'm going to look at is which was published last year, which looked at comparing patellofemoral patients with the control group. Pretty simple study, just looking at hip range of motion, whether there was any difference. It was done by a single assessor, and a digital inclinometer was used in the Thomas test position, which is a common test used by many therapists. And what was significant was there was a significant difference in hip extension, no difference in any other range of motion, something around 10 to 11 degrees, and that is quite marked. But the key question here is that because of patellofemoral pain? Is it a cause or an effect? Which we are not sure. But what we can say with certainty is there's a direct link between lack of hip extension and patellofemoral pain, especially in the chronic cases. Now, some would argue that the Thomas test is not really the best way to assess, and I would certainly agree with that because it has its limitations, which is often quoted in this piece of research by Shake in BGSM. So they looked at 14 well-trained runners, experienced runners, got them running on the treadmill at around 20 kilometers per hour, sub-maximal speed, look at the hip extension, and also compared the hip extension on the Thomas test. And there was hardly any link between static hip extension as well as dynamic hip extension. We have to remember that anterior pelvic tilt and hip extension are coordinated movements. Just because you have good hip extension passively on the couch doesn't mean that you'll naturally have a similar range while you're running. So that again shows that when you're dealing with an active population, it's always important to look at other more dynamic forms of assessment. And this has been shown by other research, one from the Stuart McGill group, where they took 24 young men with restricted hip mobility. After treatment, their range improved, passive range improved. But when you assess them in functional movements such as a lunge, the range improvement didn't translate. So we could argue that range of motion flexibility is task specific. So we can't make that assumption that there'll be a natural carryover into more functional based activity. And the recommendation was training should try to aim at grooving new motor patterns in functional movements. So that gives you sort of more evidence for dynamic mobility and warm-up. That was mainly on restriction of hip mobility, especially hip extension. How about excessive mobility? So this is something which I've been seeing quite often, is excessive hip internal rotation, especially in female runners. And that could be due to various reasons. It could be structural factors, and the number one, the most common I would say, is femoral anteversion, which is tend to be more common in females. It could be weakness of the hip abductors or the external rotators, or it could be just a motor control issue. And this study by Souza and colleagues had looked into 15 patellofemoral patients versus controls, all females. And what they found with the single leg squat, which is a common test used by most therapists, was there was excessive femur rotation, internal rotation. And that's been shown on a weight bearing MRI, an open MRI. So altered PFJ kinematics in females appears to be related to excessive internal rotation. So that was a key finding which has been shown in other studies. And the fact is that important? Is that a problem? So Leo and colleagues and one of the famous researcher, Christopher Powers, had looked into 9 females, no control group, looked them while they're squatting. And what they found was females who exhibit altered hip kinematics such as excessive internal rotation tend to have elevated patellofemoral joint stress. And that is not a good thing, putting your joint into excessive stress. So there's definitely a link between that excessive range as well as increased strain on the patellofemoral joint. Now, clinically, what I'm more interested is, by changing that, does that reduce pain? For me, does biomechanics translate into reduction of pain? And that's exactly what this group, Song and group, which has been published this year, had looked into. So they looked into 16 female patients with patellofemoral pain who had pain while they did the single leg squat. So they did a rotational tape with a simple K-tape and reproduced them squatting. And what they found was, by changing that excessive internal rotation, the pain was reduced. And this is a very useful information for therapists. So if we can change that excessive range and control that, we could possibly reduce the pain in certain patients. And it might not be a tape, it could be a verbal cue, it could be using a mirror, So the control of that range is important, and that seems to be the case, especially with the female population. In summary, looking at hip extension, I think it's an important variable and should definitely be included in the clinical examination of anyone with patellofemoral pain. Now, I'm not sure whether it's a cause or an effect, and whether changing that will make a direct influence on the pain. But I think because of the strong link, it's a key area to examine, and especially when you're dealing with a female runner, uh, looking at the hip internal range, especially the control, is a key factor. And clinically, I tend to look at hip mobility using different tests. I definitely use the Thomas test, but also looking into the reverse lunge test, as well as looking at seeing them running, which is the most important assessment. So a combination of different assessments will give us a true picture of how they are using the range. So if you want to learn more about movement screening, running analysis, strength and conditioning for runners, you might be interested in our 2-day course, which is mainly targeted for therapists involved with the management of running injuries. On day 1, we're looking at movement screening as well as application of strength specifically for runners. And day 2 is a progression looking at advanced techniques like plyometrics, dynamic mobility, and definitely a big emphasis on running retraining. The advantage is you could pick up any day because they're standalone, and further information of the course and all the details is available on the link below, and also there's an email if you need further information. I hope you found this webinar useful, and thank you for listening.